Hello, everybody. My name is Victoria Wood. I am the managing director for UBC Health. So I have one of the best jobs in the world. I get to support the team who has been leading this event. I normally work with our team on the traditional, ancestral, and unceded territory of the Musqueam on the Vancouver UBC Point Grey campus. But today I got to join our team here on the absolutely beautiful lands of the Silks Okanagan people and joining our team here. And we actually expanded the UBC Health team to the Okanagan this year. So that was very exciting for us. And then that led to hosting this event across both sites. And so this morning, I get to facilitate a panel with some faculty members who really truly exemplify the intent of this event. And they're reaching out beyond what I sometimes refer to as the Ivory Tower and really are bridging research and action. The relationship between universities and society is changing. Societies are expecting so much more from us. Looking to the health disciplines, we obviously have a responsibility to train the future health workforce. At UBC, we train, oh my goodness, across both campuses, I can't even think, upward over 20 health disciplines, often being the only educator of those disciplines. We have amazing researchers across both campuses who are conducting health-related research. But universities now, they're doing so much more. And my research really looked into what is that more? There's literature out there that talks about the third mission of universities. And so my questions actually emerged from the creation of UBC Health in 2018, which incidentally was the year I started my doctoral research. And I was really interested in understanding the expanded remit of UBC Health. We'd always focused on interprofessional education, but then we started supporting efforts in interdisciplinary research. And then we had this health systems portfolio. And so our strategic plan lays out these objectives for us in this area. And our portfolio in health systems has created events like this to foster cross-sector dialogue, has led the creation of the Gateway to Team-Based Care teaching clinic on the UBC Point Grey campus. And Naz mentioned then the Center for Innovation in Collaborative Health Education and Team-Based Care that has just been approved. And so these are the types of things that this portfolio was leading, but I was really interested in understanding the broader role of universities in the health ecosystem. And so what I actually found, particularly in the health disciplines, is that we are attracting a different kind of researcher, of academic. We are attracting people who are in the health sector. They're seeing wicked problems, things that they think need to be addressed. And they join the university as faculty members, as researchers, to be able to conduct the research to answer those questions. And what my research showed was that then they took that research, they leveraged that research as well as their education activities to advocate for changes in the health sector. They advocated for access and equity to the health disciplines that they were responsible for training. They were advocating for innovations in practice. We're seeing a lot of that in primary care innovations and the contributions that we can be making there. And they were advocating for policy change. And so they were really mobilizing their research and then playing these roles that did extend beyond the traditional roles that we might see of faculty members in this area. And so I am really excited today because I am going to talk to 3 researchers who are doing this work. So today I am going to facilitate a conversation with Dr. Jasmine Ma, who is joining us online. She is an assistant professor of teaching in the School of Kinesiology at UBC. a clinician investigator with Arthritis Research Canada, and an investigator with the International Collaboration on Repair Discoveries. She was named a UBC Knowledge Mobilization Scholar for her work bridging her role as a kinesiologist and researcher, collaborating with clinicians, community partners to create physical activity opportunities for people with diverse physical abilities. She leads the Movement for All Lab, which focuses on enhancing skills training for health and exercise professionals and supporting behavior change in strength training for individuals with chronic disease and disability. In the room here with me in Kelowna, I have Dr. Leslie Lutz, who is a professor of psychology, director of clinical training, and director of the Center for Obesity and Wellbeing Research Excellence at the University of British Columbia on the UBCO campus. Her area of research is in developing innovative treatment approaches focused on improving mental health and behavior health in order to reduce chronic disease, increasing access to mental health providers in primary care, and program evaluation of current healthcare systems. In addition to her research, she is a director of public advocacy for the BC Psychological Association. And in 2023, she started an advocacy speaker series at UBCO on realizing policy change in mental health. And last but definitely not least, Dr. Terry Shawa is the Associate Dean of Practice Innovation and Professor of Teaching at the UBC Faculty of Pharmaceutical Sciences. She holds a BSc in pharmacy and an MSc from the University of Alberta, as well as a doctorate in adult education from the University of Calgary. She has held prior academic roles in the University of Alberta and Curtin University in Australia. Terry's research focuses on pharmacist prescribing and pharmacist roles in primary care providers, with a specific interest in how to best prepare students for these advanced practice roles. In her role as Associate Dean, Terry has worked with faculty, practitioners, government, and regulatory bodies to assess innovations in expanded pharmacist scope and how that can change practice in BC. So thank you all for being part of this panel. Doctors Jasmine Ma, Leslie Lutz, and Teresa Chouard will discuss their research, the ways they're collaborating with health sector partners, and how they apply their research to advocate for changes to help transform the system. And then our goal today is really for you to leave with a deeper appreciation for how the multiple roles researchers can play in systems change, with practical ideas for how research can be mobilized in collaboration with partners outside academia. I don't know if we still have our slides on hand, but there we go. Okay. So I'm going to ask these amazing people some questions, but I do encourage you to please submit your questions through Slido. Here's the link for this session, and I will hopefully see these come up on my handy dandy tablet, and we will integrate these into our discussion today. So I think we can put down the slides now. Thank you so much to our wonderful tech team that's facilitating this across both sessions. And we'll get started with our discussion, which is why we're really here. So maybe Leslie, we can start with you since you're in the room with me. What pressing health challenges were you seeing that influenced your work?
So I am from British Columbia originally, but went to the US for my training and was there for over 20 years. And I was a psychologist in the healthcare system that could bill for my time, right? So within the publicly funded healthcare system in the US, doing my first primary care rotation over 21 years ago. So, and then was directing the PhD program in clinical health psychology before returning back here in 2015 for very personal reasons. My family was here in the Okanagan, and they asked me to direct the new clinical program and to get it accredited. When I arrived back here, I think the most stark thing I noticed right away was the absolute lack of mental and behavioral health in the healthcare system. So what I started to quickly realize is that we have a publicly funded healthcare system, but we have a publicly funded physical healthcare system. We know that 1 in 2 primary care visits in Canada is for mental or behavioral health reasons. And now our data yesterday that we unveiled in our panel discussion from our study with Interior Health and CMHA showed that 1 in 3 visits to the ER, not 1 in 20, which is the current understanding knowledge, is for mental or behavioral health crises. So what I really saw was that we currently do not have a publicly funded, mental and behavioral health program, which has really sent the urgency of my research in terms of the focus of how do we actually take from other systems, the UK, Australia, New Zealand, the US for decades that have been integrating mental and behavioral health, access to the qualified providers for the right treatment that they need in order to prevent things like cancer and diabetes and other things like that, never mind the risk of suicide, self-harm, other things like that. So that's really what I saw, that currently in our healthcare system in Canada, we pay for treatment, cancer treatment, 12 different types of cancer that are tied to obesity, but we don't treat the obesity and weight management preventatively. No different than someone's with anxiety and depression. We wait till they're on long-term disability, presenting to an emergency department at risk for death before they're getting services. So that's really kind of the urgency for me, was starting to understand how can I help mobilize and partner and make a change so that we're changing the system in terms of access.
That indeed is a wicked problem. Terry, can you talk to us a little bit about what you were seeing and that has inspired your research?
Sure, thank you. So I'm originally from Alberta, and I'm a pharmacist by training and practiced there for many years, and then moved away and came back. And around that time, just before I moved to Australia, pharmacists in Alberta were granted full independent prescribing authority. So I practiced within a system where people could come into a pharmacy and pharmacists in Alberta, both in community settings and in primary care settings, although I would say community pharmacists are primary care settings as well, could access healthcare as needed. And I don't need to speak about the primary care issues we have in this province, but clearly it adds one more access point for patients into the system. And then when I came to UBC about 2 years ago, was right around the time where pharmacists here were granted ability to prescribe for 21 minor ailments and contraceptive services. So I came really at the perfect time to look at how that is working within the province of BC, and then also pushing for and advocating for expansion of that beyond just those 21 conditions that pharmacists currently can prescribe for. Done a lot of work in the area of pharmacist prescribing, both efficacy, safety, team building around that, all those areas. And I would say, as a pharmacist who is a designated prescriber, it's what gets me out of bed in the morning, and it's what keeps me excited. I think we're educating a highly skilled workforce that should be used to their full capacity. So that's really what drives my interest in research in this area.
Awesome. I think that we often see that the challenges, but also then opportunities that really can drive our questions.
Yeah.
Jasmine, how about you? What was driving your research?
Yeah, first off, thanks for having me. And it's really nice to hear Leslie and Terry talk a little bit about their work as well, because like you said, there's a lot of overlap and opportunities. So in terms of your question, these pressing health challenges, we'll oftentimes make the joke, for those of you that are in person or online, how many of you, if you could take a pill, that would help reduce your risk for chronic disease like cardiovascular disease, diabetes, and at the same time, improve your mental health, your strength, your performance, social connectedness, and overall quality of life. Like, how many of you would take that pill? Yeah, me too. And it's exercise is just this irrefutable prevention, management, and treatment strategy that we have. So, but what we see though is our physical activity rates are really quite low. Here in Canada, depending on how you're measuring, or less than half of our population are meeting the physical activity guidelines. And so I'm coming from the realm of kinesiology, where most people don't even know what our jobs are. If it's okay with you, Leslie, maybe I'll just preface a little bit about what a kinesiologist or a clinical exercise physiologist is to then answer your question. But our KINs and CEPs really make this unique contribution to the use of exercise as an intervention strategy. And one of the unique pieces here is that we deal in movement more broadly. So that could be exercise, it could be sport, it could be rehabilitation, it could be activities of daily living, it could be even playing with your kids, right? And then the other piece for us is that our outcomes are a little bit different from physiotherapy. We definitely have a lot of overlap with physiotherapy, but it can be for the purpose of rehabilitation. But I think uniquely is our exercise intervention outcomes also relate to health or treating to target. So for example, prescribing a combined aerobic and strength training intervention to manage prediabetes, or seeing outcomes in our fitness and performance, or maybe it's wellness and lifestyle physical activity outcomes. So maybe that's your connection to land or your social connectedness, or that behavioral piece of starting and sticking to exercise. So to tie that back together around, what is our challenge here is exercise and movement more broadly is really a missing strategy in our healthcare system. And so I'm trying to figure out how do we better integrate our kinesiologists and clinical exercise physiologists into healthcare.
So somebody who has worked for almost 2 decades to promote interprofessional collaboration, I was so excited when we ended up with the 3 of you on this panel who really are speaking to the importance of all the different disciplines, the broader view of health that we need to be working towards, and how we can do that. So maybe we can start with you, Terry. Can you talk about the change that you're advocating for? In my opening remarks, I talked about this advocacy role that you're all playing. And so can you talk a little bit about what this advocacy role looks like for you and how you're mobilizing your research to support those efforts?
Yeah, so I guess the main objective of the work I do, if we were to summarize it in under one objective, is that we think about pharmacists as, like I said, an entry point into the healthcare system, and how can we utilize the most highly accessible healthcare professionals within our healthcare system to get people the care they need, and whether that's treating somebody who comes into the pharmacy with an urgent condition like a urinary tract infection, or if it's managing somebody's chronic disease such as hypertension, and adjusting their medications as they move forward in their journey. So all of the work I do is around that, or moving that forward. And like I said, having worked in Alberta where I've seen it work beautifully, and not that it didn't have hiccups, let me be clear, and not that it was easy, but almost 20 years in, pharmacists in Alberta are really making a difference to patients. So how can we better do that here in BC? And there's definitely an appetite from a Ministry of Health and government perspective to help deal with the primary healthcare challenges. So it's also about getting the timing right in terms of these changes and what we're advocating for. And I think it's about doing the work as a researcher, engaging with the partners that need to be engaged. So that for me, that's the College of Pharmacists of BC, that's the Ministry of Health, the Pharmaceutical Services branch, as well as pharmacists themselves, because I can say you should be doing this and this and this, but if community pharmacists are like, wait a minute, I don't want to be doing this and this and this, that's a challenge in and of itself. So it's engaging with all the important players, and clearly not forgetting the most important player in all this, and that's the patient. So ensuring that they're comfortable with pharmacists doing this type of work, and educating them and supporting them in their journeys. So from an advocacy perspective, to me, it's about engaging all the important players within the system to move these efforts forward.
The work that's been going on in the Faculty of Pharmaceutical Sciences at UBC is very, very exciting. When I was doing my research, did a comparative case study where the Faculty of Pharmaceutical Sciences was one of the units that I looked at. And I remember hearing a participant talk about the pharmacist clinic and when that was starting up. And initially, the ministry sort of, I think it was of advanced education of time, changed its name since, but it sort of said, well, wait a minute, this isn't what a university does. And then they thought about it and they said, well, no, do you know what? This is exactly what a university should be doing. And then that pharmacist clinic has played such an amazing role in integrating pharmacists into primary care. And so I think it really did show that expansion of the role of the institution and the faculty members within it to be then creating that systems change, particularly when it comes to access to those important services.
Absolutely. Totally agree.
Jasmine, how about you? Can you talk about your research and how you're leveraging that and what sort of advocacy work you're doing and what change you're working towards?
Yeah, sure, Victoria. So broad question here is how do we better integrate our kinesiologists and clinical exercise physiologists or CEPs into healthcare? And I think that the context there is both in the public setting, but as well as in our private and community settings. I think there's roles in both. So my primary area is in curriculum development. So how do we identify best practices for how we train competent kinesiologists and clinical exercise physiologists? There's also work that we're doing with the Ministry of Health. You know, in 2022, KINs and CEPs were named as part of the Allied Health Strategic Plan, which is, you know, fantastic news for us in our field. And the ministry has since then committed to supporting the training and integration of CEPs into healthcare. So all very exciting, and that's sort of some new stuff that we're working together on. I've also got some work as an implementation science fellow to study team-based care in UBC. We're getting this new, really exciting gateway clinic that's meant to be a model and almost sort of like a learning health system for team-based care, where you know, to have a CEP integrated in there is really exciting for us. So you know, taking that opportunity to study the implementation and education best practices. But I think similar to you, Terry, which you mentioned, like at the root of all of this, it's really co-development. You know, we have a lot of relationships to be made with other disciplines. We need role clarification. And at the core is like, we need to hear from our kinesiologists, our clinical exercise physiologists, our students, their clients, in addition to other healthcare professionals in government, for their voices on how to optimize and sustain our approaches. We don't want this to be something where we test something here in a local setting and it stays there. Like, we need something that's scalable.
Yeah, thank you. That education piece, I think, is so important. And so often, you know, I think we are training students to go into the current health sector, but as a university, really looking to how we can train them for the future, for an unknown future, or a future that we're really, you know, we see the potential of, and how do we train our students for something that maybe doesn't exist at the moment, but that they then become those vehicles of change. Leslie, how about you? Tell us, I got to hear a lot about that yesterday, and I'm excited for you to share sort of the advocacy work and how you're really mobilizing your research.
So I will say, our colleagues in pharmacy, you were really trailblazers. I know over the last several years of the work of the PC Pharm program about integrating into primary care. And we have talked a lot with your colleagues about learning lessons, what went well, what didn't go well, right? And so that's been already one really fantastic collaboration. And with regards to advocacy, I want to be clear, I'm not an expert. I didn't have training in it, right? This was learning on the job. I actually recently wrote a paper of hoping to change mental health care policy to get it right in the end based on everything we've done wrong so far. So I joke that that's one of my most cited papers, not my JAMA publications or other things. Essentially, what I was trying to lay the foundation for understanding is that all the things that we've done wrong in academia, and I say we as in me, or in the field of psychology, is that we have so many white papers. We're so fantastic at having these great summative documents, but a white paper, absolutely necessary, is not sufficient. White papers go on ministers' desks to die if it's not followed up on. So 5 years ago, the British Columbia Psychological Association hired me for 5 hours a week to be their first director of advocacy, to actually put, not just off the side of my desk, but to actually put that time into action. And in the very first week, I was in the leader of the Green Party's office in Victoria. I was visiting with MLAs across the province. And that was really where the things started to change in terms of understanding the relationship, starting to work with doctors of BC, starting to form those relationships. And for the first time in history, last year, Doctors of BC endorsed psychologists as being a critical partner within primary care. And this has never happened before. So in 2020, the Canadian Medical Association said that patients need not just diet and exercise recommendations alone, they need access to evidence-based treatments to address the root drivers of obesity and maintaining factors, and that includes cognitive behavioral therapy. So getting alongside with our medical physicians and primary care champions that are already doing the work, that was really help paving the way. And then also doing research. So here on this campus, we're actually already doing integrated primary care. Our student health clinic here, the physicians, the nurses partner this past year and a half with me as a psychologist, side by side, right? Getting real-time referrals and coordinating the care with a psychiatrist that we have virtually, and really allowing the research to go directly into the hands of our government right away. Same with our partnership with Interior Health and the Canadian Mental Health Association for the last 3 years, which has resulted in yesterday Minister Josie Osborne announcing a provincial-wide suicide prevention framework. And so honored that in meeting with Minister Osborne, understanding that our work and our research is getting right to their desks right now to help inform policy change. So I would say, right, keep doing the research, and that's necessary, but not sufficient. And you've got to actually partner with all the other individuals, but you have to move this towards government because they have the same urgent issues. You just need to partner together to figure out how to get there. That's really been what I'm learning from what we've done wrong, and hopefully to get it right moving forward.
When I interviewed leaders from across the health disciplines, they talked about we needed to think differently about how we support faculty members. You mentioned I wasn't trained in this, and they said we need to be supporting our faculty members to train and engage in these efforts and do and disseminate and mobilize their research in different ways and recognize those things in promotion and tenure so that it really is, how we're doing things and moving away from, academic publications that, different people read those, let's face it. So our next question is about how you're working with communities and health sector partners to advance these goals. And I'm pleased to see that we've got some questions on Slido as well that I might sort of integrate into that particular question. I do have those in front of me, so I don't know if we need to have those on screen necessarily. I'm enjoying seeing everybody's faces. And so maybe this is sort of directly related to that question of working with community and health sector partners. So there's a question for you specifically, Leslie, about what do you see as some of the biggest opportunities for the health authorities to impact mental health behavior and behavioral health?
So I think, right, gaps in care have really been significant. Hearing people in ERs, right, getting acute mental health care, and then having nothing to go back to, right? Upon discharge, they say follow up with your primary care provider, and the primary care provider doesn't have access to those, and then you're left up to your own devices. So where do I think the health authorities have opportunities? That one of the things that I've been working on and advocating for is the development of a provincial-wide referral network. And this is already, again, I'm not a genius. I didn't create these things. This is already in place in Ontario, has been working incredibly well for 3 years, where patients and physicians can refer in. It's a partnership between government and the Ontario Psychological Association. And then they partner, and then they connect back into the primary care network through their EMR and things like that. It's been so successful that now they've partnered with all the health authorities upon discharge, that they're utilizing that referral network as well. Nova Scotia has just signed on to do the same thing, and I'm trying to advocate for that creation as well. I'm also really trying to articulate and advocate that in our public sector, for example, with psychologists, there's over 1,700 in the province, but currently only 12% of them are in the public health sector, with 90% almost in the private sector. How do we increase access to those mental health specialists, right, that are regulated providers with competencies in assessment, diagnosis, and evidence-based intervention that's evaluated for effectiveness across time? Those kinds of things I'm advocating for, starting to have metrics, right, that we should be understanding rates of anxiety and depression And when we provide the treatment, just like we do in cancer, we would not provide the cancer intervention and not assess whether that tumor went down across time. But currently, not only do we have the metrics to start with for where we're at with mental and behavioral health, we don't actually evaluate for treatment effectiveness. So one of the things I'm working with is really trying to advocate for understanding the metrics, the creation of those, but also the opportunity for connection with mental health providers that can coordinate with our physical primary care teams, and to really help start to decrease the need for emergency visits. We know the UK has shown repeatedly since they've been doing their IAPT program called the National Talk Therapies now for over 20 years. When you effectively treat anxiety and depression in primary care, you reduce ER visits, hospitalizations, obesity rates, cancer rates, cardiovascular disease rates, early mortality, morbidity. So these are the things that we don't currently do in British Columbia, but we have to start somewhere, and starting to evaluate and understanding where we're at as a mental and behavioral health, and then starting to intervene and have access to those providers, I think has huge implications in terms of that ROI our first panel was talking about. Exactly, significant, but we have to actually start collecting that information to understand how we can impact the trajectory.
Feeling overwhelmed. Lots of work to be done. Jasmine, we have somebody who's curious about your experience at both UBC Vancouver and UBCO in terms of how knowledge mobilization is done in big or small cities. So sort of those contextual pieces. And by the way, Rachel says hi.
Oh, hi, Rachel. Yeah. I think at the root of it, when we think about doing knowledge mobilization, what always sort of brings me peace of mind, and Rachel, you know this, that I love theories, models, and frameworks, is, the principles are all the same, but the context and the people that you work with, they change, from site to site. I think one of the biggest things that I've seen as differences between UBC Vancouver and UBC Okanagan with a lot of the knowledge mobilization work that we're doing is UBC Okanagan is much smaller, and so you know exactly who to talk to, right? Whereas in UBC Vancouver, when you're thinking about the different levels of intervention, sometimes to get to each of those layers, there are just more people. So in either case, though, I just sort of remember there's the relationality piece of how we do knowledge mobilization. And that's at the root of it, just be a good person, right? And then there's the systematic piece of, how do we actually recognize that partnership isn't just the feels, but it's also a scientific process that, there are steps and ways in which we can foster good, meaningful engagement with our partners. So yeah, I don't know if it fully answers your question, Rachel. I think at the root of it, the process is the same, but it's in recognizing, just really getting to know your context and the people that are there. So I wouldn't say drastically different, but in many ways also different in the same at the same time.
Terry, maybe I can direct this one to you. There's a question here about how do you engage health leaders at the health authority early in the research process to co-create knowledge and solutions?
Yeah, and I would preface this by saying that not having graduated from UBC or been in the BC context until 2 years ago, I was really starting from scratch. And although pharmacy is a very small world, it was still hard to sort of make those inroads. Thankfully, the previous Associate Dean, Peter Zed, was super helpful in helping create those relationships when I got here, and giving me the names of the people who I needed to know. And I think that has made a big difference. And from specifically a health authority perspective, within my portfolio, I have, there are pharmacists who represent each of the health authorities. So they're practicing pharmacists who are half-time health authority, half-time UBC academics, and they provide me excellent ways that I can interact with those other health authorities. So if there's something I'm questioning about that could work potentially in Northern Health, I have somebody immediately on the ground that I can go to. So having those connections and really using those connections to help make introductions to to all the people. And so just like Jasmine had said before, I think it's about knowing who's in the space and who you need to engage with. And I would say I am not, like Leslie said, I'm not trained to do this work. I'm not an extrovert. I'm not the kind of person who's going out and shaking hands and kissing babies. But just having that initial sort of one-on-one discussion with people really does help to open doors and makes the work a lot easier to engage with those people.
Throughout all your comments, collaboration with others is just such a strong theme. And we have a couple of questions here from participants talking about, the challenges that you might be seeing when it comes to collaboration, particularly interdisciplinary collaboration, and how you think we can improve the systems that hinder collaboration and really move beyond that individual desire to collaborate and put it more at that sort of systems level. So maybe I'll just open it up to the three of you to see who wants to take a stab at that. Jasmine.
Yeah, I'll just make a pitch for, when we think about changing things at the systems level, we can take a look at the whole system, and ultimately you do have to understand that everything, when you're looking at that systems level, you've got that inner and outer context that, play with one another. But the thing that brings me some help in this area is remembering that systems are still comprised of individuals. So when we have conversations with individuals, right, and we get an understanding of what are the factors that affect an individual's ability or decision, or facilitate their means to change, then I think that helps us to understand systems problems a little bit better. So I'll just add that small plug there is remember systems are still individuals at the root of it.
Absolutely.
I'll jump in as well and just say that, systems are hard. We have to work within the systems we have, but I also am a believer in not just because that's the way it is doesn't mean it has to change or it has to stay that way. It can change. I think from a pharmacist perspective, a community pharmacist perspective, they would say they want to burn their fax machines because that's our main form of communication with primary care physicians. And it's just obviously a ridiculous antiquated system. So, really addressing how can we work that better. Yesterday, there was a talk on the PCN and the pharmacist and PCN program, and one of the big findings they had was that it makes more sense to have the pharmacist co-located within the clinic and to also not have pharmacists access mediated through a referral system. So, can patients access the pharmacist directly? So, looking at those workings of the system and investigating that and how can those change to better improve access to care for people.
Yeah, I think those are both great comments that I agree with. And I remember several years ago attending a talk by Peter Cornish, and he was talking about system transformation. And he once said this, and it still speaks true today more than ever. He said, system transformation happens at the speed or pace of trust. And that's really what I have actually tried to spend the last 5 years doing, is garnering trust with our patients as point one, trust with our partners in academia, partners in health authorities, our physician partners, our government partners, right? To know it's not an out to get them or to tell what the problems are, right? It is solution focused, it is positive oriented, it is respectful, and it is collaborative. And that is why I don't do any grant on my own or any project, because that's how I've gotten things done, is that our work is better, more meaningful when we have more people as a part of the team in terms of help contributing. So I feel like that trust thing has really spoken true for me every single time. And I feel like I've had such great experiences with the CMHA IH partnership the last 3 years. People are like, how did you do that? We've had so many challenges. I said, they were amazing. Every time we had a challenge, the team responded with an email, a call, a text message, and within a week, the problem was solved. And so, but it was all with that trust that they knew that I absolutely respected and appreciated everything that those physicians and nurses were doing in the ERs. And no matter what the data showed, it was that they were going to be the first group to actually start showing the data upon which then we could make improvements. So I think I can't underscore that enough, is that trust has to be there, and that it's amazing that things can happen when you have it.
I just finished that book, Speed is Trust. So relationships, trust, themes throughout this conversation, as well as a lot of the other discussions we've heard throughout this event. Maybe what I will do, just building on, I think, the panel we heard this morning, take one last question from our Slido here. And I don't know who wants to tackle this one. It's a good one. So how do we reduce the evidence to practice gap when funding depends on demonstrating results, but we need funding to create the pilot projects? Has anybody had any sort of experience with that they maybe can draw on some success or lessons learned? Terry, you're leaning in, Terry.
Yeah, no, I'm laughing because, that's we all try and do this work, and we can't do it without adequate funding. I will say that I've had much more success in the BC context than I have elsewhere, and I don't know why that is. I think UBC does have offers a lot of funding opportunities for researchers for these pilot or small start studies. So, and the Ministry of Health has a lot of funding that we've been able to tap into as well. So, in comparison to my previous institution where there was no money for anything ever, I feel like it's much better at UBC, but at the end of the day, we all have more ideas and more desires of identifying solutions for the system than there is money. And I don't know the solution to that. I think we like to mobilize a lot of student works, a lot of directed studies, a lot of work learn students to help do some of the fundamental foundational work, but at the end of the day, you do need some funding to move things forward.
Maybe I can just put a plug in for the collaboration that the panelists talked about this morning as a mechanism to sort of even just bring our resources together and be able to do those pilots.
Yeah, so perhaps I'll just add to that. I think probably in the last 8 years, the majority of my funding has not come from CHR or SSHRC. It's actually come from private donors and from mental health associations and our other partners directly reaching out. So I sit on the panels for the federal grants now, but actually the majority of the work that I do is now funded through these other, and I love that the UBCV initiative for collaboration grants, where they actually just tiny little grants where you got to spend time to fly down and back and forth to have communications. That's resulted in 2 significant grants for me. That was seed funding. And so I've been a big advocate for that to UBC. I really like that. But I think understanding, getting out of the traditional view of it's got to be this grant, SSHRC and CHR. I've long advocated to UBC. I hope that they start looking at other metrics, as you said, for success. And it's not your citation index, and it's not how many times, right, your family reads the publication or it's referenced, right? It's the impact that you make. And so I really have been grateful to the donors. So in 2018, for example, one private donor came forward to fund my walk-in mental health clinic, the first of its kind in BC. And now to this day, we've seen over 7,000 patients across the province that otherwise would not have access to real-time mental health services by regulated mental health specialists. And we expanded that during COVID, right, to virtual and online. And that was started by a funder. And the only request was within 2 years, can you find it and make it permanent? Within 1 year, UBCO, once I brought them the data, made it permanent, expanded it to 2 days, and now it's a permanent offering. So these are examples of where you can have small funding or donor funding or other things, and that go to your leadership and go to your government, or go to your MLA, that they can actually look at making things permanent. That has been a very big different avenue for me to think about. But I also appreciate and respect that I'm a full professor. So I right? Only do things that I find meaningful. I don't care about SHRC and CHR in terms of those number. And I hope that as an institution, we get towards understanding it's about meaning and value and impact, not the sources of how much what you tri-council funding agencies, but funding, yes, you need it, and advocate to UBC for seed funding, but donors, there's a lot of people out there that want to support the work that people are doing, and our administration listens. I feel incredibly positive, not just at our administration level, but at the government level, of that they're listening when the science is being brought directly to them.
Jasmine, did you have anything to add to this question before we sort of start to wrap things up?
No, I think Terry and Leslie highlighted really nicely how we sort of reframe what do we mean by impact, and start to think a little bit more broadly and creatively around what our funding sources are.
I have absolutely loved this conversation and the conversations that we had leading up to this panel and talking about all the things that we could possibly do. And so what I'd like is to end within the last 10 minutes that we have is sort of really where you all see efforts needed in the future. And, you know, we really wanted a panel like this to lead to action and something that, you know, maybe we can all collaborate on going forward, what we might be doing to build on some of the things that you've talked about today. So I wonder if I can sort of just go to each of you in turn to really just talk about, you know, what efforts do you see us needing in the future? And Terry, maybe we can start with you.
Yeah, and I'll start by saying we're super excited to be part of the Gateway to Team-Based Care project here on campus, and you know, looking at a true team-based care environment, both from an education perspective, so that our students get to experience that, but then, you know, how can we make it scalable to other places? So I'm super excited about all the opportunities that will come out of that work, and how we can, you know, lead that development from Gateway Clinic. So I would say that's something I'm really looking forward to. Lots of other things, of course, that I want to do, but that's top of mind for me right now.
Jasmine, how about you?
Yeah, I think for me, from the kin context, is still we're pushing for that distinction and awareness of what our scope of practice is, and so that, you know, when we say we're kinesiologists and CEPs, people know what that is. I think there's a real need for the recognition and role of implementation science. So how do we advance our integration as a field as a whole, and not just within our individual sites? And, you know, I think to some of our coordinated efforts across our PSIs or other universities to set these quality standards for our graduates that we produce. Well, you know, for kin, we also still want to maintain our interdisciplinarity of kinesiology. So we're not solely a health professional program, which I think is a little bit unique for us. And so that is also a bit of the beauty for our programs, is sort of balancing this transition as a health professional role, but also maintaining the interdisciplinarity of kinesiology and theory. But then the interdisciplinarity of kinesiology, but also across our professions, right? Yeah, everyone here, we've got evolving scopes of practice and evolving ways in which we're integrating into healthcare. And I think the more that we take a coordinated effort towards that, instead of reinventing the wheel, I think we'll all benefit. Maybe one last thing that I'll just put a plug in for, mindful of, you know, any graduate students or postdocs that might be listening in. Well, Rachel, you know this, but we've launched a knowledge mobilization research to impact fellowship here at UBC. So we take on about 20 students and really train you in what is, like, how do we bridge research into practice? And well, while our application is closed for this year, we have, if you take a look at the knowledge mobilization unit website, we have some online training, and you can look for the application that opens for next year.
Very exciting initiative indeed.
Okay, so perhaps I hope it's okay. I'm going to be a tiny bit controversial here at the end. So I am thrilled about the announcement of the Gateway Team-Based Care program in Vancouver. I think it's wonderful and exciting and long overdue for sure. But when I reviewed who's a part of that team-based care initiative, and you're both nodding your heads, that neither psychology or psychiatry is a part of that team-based care initiative. And so, but yet is the standard of practice that psychology and other mental health specialists have been part of primary care for decades, right? In our other systems across the globe. In fact, actually, a psychologist was the architect behind the IPT program in the UK, David Clark, who's at Oxford. So with health economists and stuff. So I think I want to urge us from, if we're talking about wanting our government to use the evidence base to inform policy changes, I think that actually starts right here at home and how we make our decisions for how, right? If team-based care, right, is a priority, which I love that it is now, let's ensure that we have, right, who is coming in the door as primary care, as patients, and making sure that our team-based care, is consisting of the providers that can provide that comprehensive assessment, diagnosis, and evaluation and intervention that's needed. And I will say, Tara, I 100% agree with you with the co-location. So I have been advocating saying you cannot put the other providers in a different building in a different part of town and think that you're right. The model is very clear that co-location is critical for, even if it's virtual. So even if we have virtual real-time as a component of it, putting them in separate locations, we know that the research is very clear how that impacts outcomes. So I absolutely co-location am a fan of that and hope that we can utilize right here at the Okanagan, thinking about virtual real-time service is a huge component of what could be accessing for our patients in rural communities, that while it's optimal if we have someone in person, what's more important in terms of saving their lives and providing the care that they need is the effective care provider in front of them, whether they're in person or virtual. And that's really something I've been working with the virtual real-time teams to talk about. How can we integrate mental health providers as a part of the team, even if they can't be there in person? So I am super excited by what is going on in the last several years, particularly with UBC coming on board with understanding that training is actually part of what we should be doing for our students, not training them in books, but in real world, at the same time as providing access to our communities, both here and in Vancouver, right? Forward-facing clinics and training opportunities that train, and we can collect metrics of data for research, but also for community, for patient care. So it's been an honor to be a part of this last 2 days, and I'm really excited. And thank you to my colleagues on the panel. It was great to hear the work that you guys are doing. And I think we have big problems, wicked problems, as you say, but I actually think we have some pretty wicked people and agencies and government leaders that really want to make the change that we know is needed.
I think we've got three pretty wicked people here. And, I think, comments about the integration and the importance of psychology and other professions into something like Gateway speaks to relationships and the need to have those relationships to be able to make that happen. So hopefully now that we're friends, we can continue this discussion and figure out what that looks like. And of course, Terry, you spoke to the ability to then scale the models that we're going to be testing. And so that speaks to the types of advocacy work that you've all been doing and how we really do take the innovations and the research that's happening within our universities and do scale those across the province. So I would like to just thank the three of you so much for taking the time to be on this panel, to the participants at both sites who asked more questions than I could get to. So we'll see if we can kind of pull those questions out and make sure we're sending those to you, especially the ones that were directed specifically at any of you. So we do want to make sure we continue this dialogue and the collaboration and relationship building that you've all spoken to. So thank you all so much, and I hope you enjoy the rest of your sessions.